This podcast is produced by the Center for Deployment Psychology at the Uniformed Services University of the Health Sciences. The views expressed are those of the speakers and do not necessarily reflect the opinions of the Uniformed Services University, the Department of Defense, or the U.S. government. In addition, references to any specific companies, products, processes, or services does not necessarily constitute or imply endorsement by the Uniformed Services University, the Department of Defense, or the U.S. government. Welcome to CDP's podcast, Practical for Your Practice,
where we give you actionable intel to support what you do, one colleague to another.
Hello and welcome, or hopefully welcome back to Practical for Your Practice. I am Jenna, Ermold, one of your hosts, today with my co-host, awesome editor, jack of all trades, Kevin Holloway.
I said in the last episode that that's the only reason I keep coming back to these, because I love these affirmations that I get from Jenna. So
yeah, it's the only time.
So we've done three episodes in a row. So I mean, yeah. I'm feeling so good at this point. I appreciate that.
That's great. This is really exciting. So I feel like we're hitting some topics this season that we have not hit before that are really critical topics that a lot of us are undertrained in, or disorders or treatments that a lot of providers have good intentions, but somehow they kind of don't feel like they don't go down this training path, or believe it or not, we all kind of specialize as we move on sometimes, and we don't cross over into this area. But fascinating and really excited to be talking about OCD today, obsessive-compulsive disorder, and especially exposure and response prevention, or exposure with response prevention. I probably just said it wrong, so we'll have our amazing guests correct me on that. So we have with us today Liz and Lauren, and if you can please welcome to the podcast and say a little bit about who you are, what you do, and then we will talk all about everything OCD after that.
Okay, so hi, my name is Dr. Elizabeth McIngvale. I am the director of the OCD Institute in Texas. We are one of the few OCD-specific residential programs in the country, and co-founder with Lauren of Mentee, which is a really exciting new age training app. And really both of our worlds just collide in so many different ways. So we're really excited to talk about that today. And I think it's really what we both do is based exactly on what you just talked about, Jenna, which is the goal to bring evidence-based training, but also help people understand what training do you need for what disorders that you're treating. And I think that's just something we see such a gap in, and specifically OCD, it's often mistreated, misdiagnosed. And I've been doing this work for decades as both a clinician and then as an advocate. I serve as a board member on the International OCD Foundation and one of their faculty members for their training institute. And I'm just really excited to be here.
Welcome. That's great.
And I'm Lauren Wadsworth. Thank you for inviting us. I am a clinical psychologist, did most of my training at McLean Hospital in Boston, and then brought everything amazing that I learned back to the rural areas in Western New York. So I started a few practices out here. One insurance-based clinic named Jenna Valley Psychology that has a comprehensive DBT program, as well as an OCD program that has both intensive level of care, intensive outpatient, and regular outpatient care, group and individual, the works. And then I also started a group practice incubator, if you will, called Meridian Practice, where it's a self-pay model and clinicians can build up side practices that support them doing evidence-based practice or insurance-based practice elsewhere. So also really passionate about training. We have PhD students, practicum students, MHC students that come through the clinics, and we have been obsessive about training them in OCD and other evidence-based treatments, specifically in the CBT realm. So in starting the Mental Health Network and Training Institute, or Mentee, with Liz, we are trying to figure out how to take everything we learned in growing our different size practices and different types of practices and make that scalable education to reach folks like me who are in rural areas and maybe don't have access to training in places like McLean or Boston.
Awesome. Well, we are again really grateful that you're taking the time to help educate or continue the education of our listeners, many of whom might have tons of experience with OCD, and some of whom might not have any. So we have a wide range there. So especially, given that there will be some folks listening who maybe don't have a ton of experience, let's maybe if we can start by grounding ourselves and our listeners to make sure we're all on the same page and really talk about what is OCD. It is one that gets represented in pop culture quite frequently, sometimes misrepresented in pop culture. So, there are lots of stereotypes we might need to address. If we could just talk about what are the key features, and especially how does the cycle of the disorder develop and maintain itself?
Yeah, so OCD is obsessive compulsive disorder. It's really made up of two things. So these obsessions and compulsions. The obsessions are unwanted intrusive thoughts, unwanted being the most important part of that definition. And then the compulsions are repetitive behaviors that the person does to get rid of those intrusive thoughts that also do not bring them pleasure. This is really important. I think a lot of people get confused about, most of us have obsessions, most people have compulsions, but sometimes they're pleasurable, right? They enjoy the football teams that they watch, compulsively or whatever it might be. That's not OCD. It's enjoyable. It brings pleasure. And I started a nonprofit years ago, and we used to make like t-shirts with different slogans. And my favorite slogan that we coined that we use all the time now in the OCD field is OCD is not an adjective. And if somebody were to ask me, what is one way you would want to help people understand the misconceptions of OCD? It's that it's not an adjective. You should not be, if you're saying things like, you should see my coworker's desk, she's so OCD, or you should see my mother-in-law's kitchen, she's so OCD. We're probably not talking about OCD. We're probably talking about preferences and personality and the way individuals live their lives, but it's not necessarily disabling and debilitating. And I think that's the last thing I'll say is that OCD, when left untreated, is one of the top 10 reasons people file for disability worldwide, cost the US economy over $8 billion in lost productivity. And it is it's 3% of the population is impacted by OCD, making it one of the most prevalent conditions. So I think a lot of people don't understand the true disabling nature of this disorder when it's left untreated and how many people it impacts.
And just to touch on the way in which it maintains itself or how OCD is maintained, as Liz was saying, someone might have an obsessive thought that is intrusive, unwanted. It could be something like we hear about in the media all the time, like my hands are dirty. So the thought is, or I should wash them, right? That's the compulsion would be to wash. OCD can also include infinite number of themes. So some of the favorite ones that I like to work with are the more taboo themes, ones that are really hard to talk about or admit that you have. So that might be intrusive thoughts of I'm a pedophile, or I could kill someone, or I could lose control and jump off a bridge. And then the compulsion might be something that is purely internal. So it could just be thoughts that are popping in and then compulsions in response to those thoughts, like, well, I've never, had any sort of relationship with a child, so I'm probably not a pedophile, right? Reassuring oneself. Those can be really hard to catch or know that one has, because there can be no physical compulsions in some cases of OCD. So compulsions can be physical, they can be mental, they can be relational. It could be that you ask a friend, do you think I'm a bad person? Do you think I'm capable of murder? And then getting reassurance that way. So what our brains learn is that when we have an intrusive thought, our anxiety spikes. That's worst case scenario for a body, a mammal body, right? Like from the whole history of time. And the goal is to reduce that anxiety as fast as possible. And with the case of OCD, rituals reduce the anxiety almost immediately, not forever, but they do have an impact of reducing that anxiety very quickly, which then trains the brain that anxiety is dangerous and rituals fix it. So that is how a person with OCD gets caught in the cycle where rituals feel like life and death. I have to do this or else I am going to die. And that could be death by uncertainty or anxiety, but it is something that feels so naturally terrifying that it's not a choice, right? People are getting trapped especially initially. Eventually, we think it can be a choice to compulse or not. That's a big part of treatment that we'll talk about. But people can get sucked in so fast because our brains are primed to be looking for things that reduce anxiety as fast as possible. And that's what
Yeah.
rituals do.
And in many ways, it makes sense because it works, right? Like
Right.
folks aren't crazy, and I hate that word anyway, but they're not crazy for doing this because it works. They're rewarded for it, at least in the short run.
Exactly.
That's right. Yeah. So everything is maintained because, and that's, I think, why I fell in love with this work, is because it is so fascinating. And when you look at like what's happening physiologically, you would see heart rates increasing, right? You see these true physiological responses to anxiety.
Mhm.
Like the anxiety is real. That's not pathological. It's actually there. And the rituals, at least at some point, reduced or eliminated the anxiety. And so, of course, it maintains itself. Like, who doesn't want to feel
Yeah,
better?
right. You said, Liz, earlier that oftentimes OCD gets misdiagnosed as other things, and you were talking a little bit about that. I think, trying to make the distinction between somebody who prefers orderliness and, general cleanliness. I mean, even to take into an extreme, that's still something slightly different. We could call that obsessive compulsive personality disorder,
That's
right?
right.
Like I'm thinking
That's
of
right.
a college roommate that I had who would get really upset if somebody would walk by and kind of turn one of the pencils on his desk a few degrees. Like he
Yep.
would get really upset, and maybe to the point where it's dysfunctional. But I mean, and maybe not. But it occurs to me that that's not the only thing that could, if somebody misses OCD, misdiagnoses it as something else, there might be other things too. So, what are some of those other
Yeah.
common misdiagnoses if we miss OCD?
Yeah, I think OCPD is a big one.
Hmm.
And I think, oftentimes people are, getting a diagnosis of anxiety NOS, generalized anxiety disorder, phobias, like and lots
Yeah.
of things in the anxiety realm. And then ADHD for sure, especially in kids and adolescents, we'll see a lot of
Mm.
misdiagnosis there. And then sometimes it goes the opposite way too, where sometimes we're getting a lot of patients in the res level of care that have an OCD diagnosis, but it's actually better explained as bipolar or better explained
Right.
as a psychotic illness or thought disorder or something else, but like their obsessions and compulsions are really significant, but they're better explained by something else. So, I mean, it can go both ways, but I think most often than not, most of our patients have had a GAD diagnosis at some point or ADHD or, kind of anxiety NOS, and people are doing more talk therapy or supportive therapy, which by the way is not what's evidence-based for anxiety anyway.
Right.
And so of course they're not getting better, but really if you're not doing like CBT alone doesn't help OCD, it has to be exposure response prevention. And that's really important for people to understand.
And I think that's, again, when we're talking about folks not having training, or even just the example you gave in the general population of, and I think it was you, Lauren, the friend that assures you you're not a pedophile, or the person in your life that reassures you, whatever the thing is doing it from a good place, right? Or you might even, as a therapist, be doing talk therapy and thinking you're sort of, doing this from a good place of
Mhm.
trying to alleviate anxiety, when, of course, we know that that's actually perpetuating what's going on for the person.
Yeah, and even when those support folks learn the treatment, it's painfully hard. Even when you learn you're not
Yes.
supposed to give that reassurance and you're all on the same page, to have a friend come to you or a child come to you or a partner come to you and say, I just need you to tell me this one time. I'm freaking out. Watching someone have a panic attack and quote unquote not do anything aside from validate is just so hard. It's so hard to do. So props out there to any parents who are navigating this. It's not you. It's a very tough diagnosis and disorder to treat.
Absolutely. Just full disclosure, Kevin and I train in prolonged exposure therapy. So we're very big proponents of exposure for sure. But recognize, I mean, we obviously see some similarities with, please just come with me to the grocery store. I need
Hmm.
you to come with me to the grocery store. But anyway, okay, we've mentioned this notion of exposure and response prevention, that this is the key element. And we know hands down has the most evidence. And but they're again, so for our listeners who might not be as well versed in ERP, which is what we call it, how does this technique work? How does it disrupt or maybe kind of sever that relationship between the obsession and the compulsion, or the ritual, and play out?
So we know with OCD that we can't just remove someone's intrusive thoughts. All humans have intrusive
Hmm.
thoughts. People with OCD have them more frequently and likely have a higher anxiety response to them. So we're not going to try to reduce those. We're not going to try to change the thoughts, to do thought stopping. What we're aiming for with ERP is to change the response to the thoughts. So exposure means that we're going to try to trigger, kind of call out the thoughts from the shadows intentionally. So we might look at pictures of children or touch a doorknob or just read a script, do anything that might trigger OCD to start getting loud. We're going to expect that anxiety is going to spike, maybe even worse than when you're on your own. We're going to talk about how anxiety is survivable. Every wave of anxiety comes and goes. And when that anxiety spikes, we're going to resist ritualizing. So exposure and response prevention means exposure and ritual prevention, basically. So we're exposing ourselves, we're expecting the spike, and then we're going to let it pass without engaging in a ritual. And the difference from what we were talking about with the OCD cycle is that your brain learns anxiety is scary, it's not dangerous, and it passes on its own, right? We're not trying to change that anxiety is hard to have, like it is. Nobody wants to feel a 9 out of
Right.
10. And we can survive that, and we can wait it out, and every spike, every 9 passes. So to have someone practice this is extremely hard to do, and it's also extremely exciting to watch as a therapist. I mean, seeing people go to the brink of life, that they feel like they're walking through hell, they're risking it all, and then to come out the other side is just so empowering and exciting to see.
Yeah, for sure. I think similar to some of the
Mhm.
things that's really great to see with prolonged exposure
Mhm.
therapy for PTSD. I mean, they kind of ERP and PE kind of had similar roots and grew up
Yes,
together,
totally.
perhaps. And yeah. So you mentioned though that the treatment can be challenging for, family members, for significant others, partners, but I imagine it's also can be challenging for the therapist too in several ways. And I think about that as, there's challenges that we encounter as PE therapists, but also I'm thinking about a case I had in my graduate training in our community clinic there, where this particular client was dealing with a pretty difficult, I think, form of OCD, where it was around a lot of contagion and cleanliness, but that resulted in like this 3-hour shower ritual. Like it took so long. And so because it took so long and was so disruptive, she would then also usually skip it and then would feel like she couldn't go out in public. And so most of our work was about just trying to get her to come to the clinic.
Mhm.
So I wasn't allowed to go to her house. Um, and so I mean, I think about that, and I think about kind of the experience we've had with PE as well, that sometimes these symptoms are the very things getting in the way of them engaging in the treatment and getting the benefit of the treatment. Like the symptoms are in some ways, if they are allowed to continue, preventing them accessing that good care. So I wonder if you had some thoughts about that, some of the challenges from the therapist side.
Yeah, I mean, I think that's something we deal with and think about every day when we're treating OCD, especially on the more severe level. And I think that this is where I guess I would push clinicians to think about what is within our wheelhouse or not, right? And
Yeah.
when we think about level of severity, especially for OCD, we really have to think about level of care, because at the end of the day, if a patient cannot do ADLs, I was just doing supervision this morning with our fellows, and it's like, okay, like they said, how do y'all know so quickly, like when somebody needs a different level of care? Because I can usually tell in the first 10 minutes, right? And it's like, okay, what are we really looking at? We're looking
Hmm.
at impairment. We're looking at like how are they functioning, right? But also I'm looking at, is it feasible for me to expect with their current level of symptoms and severity that they can maintain progress in between outpatient sessions, right? If somebody is doing a once a week 45-minute outpatient session, but they're engaging in 10 plus hours of rituals a day,
Right.
we're not going to be able to really move the needle appropriately. It's kind of like saying, hey, I fractured my foot in 3 places, but like I'm going to use an ace bandage and hope it heals. Like, no, you probably need a cast. Like it's not going to heal that way. And it's going to be really painful every time you keep trying to walk and wondering why it's not getting better.
Yeah.
And
Yeah.
so I think we really have to think a lot about level of care. And this is why so many patients with OCD that have severe OCD need a higher level of care, because why? Well, their OCD impacts their ADLs. So
Hmm.
when your OCD is so commonly impacting eating, preparing meals, using the restroom, taking a shower, right? These activities of daily living that we usually don't do in session in an outpatient
Yep.
session, right? We're usually not in the shower with someone or coaching them through shower routines or cooking meals, there can be this mismatch between, okay, I know what this patient needs to do to get better, and I can't be with them during those times they actually need me the most, and that are the reasons they're actually showing up for therapy to begin with.
Yeah, I feel so validated, I will say, because I've always felt like that was not an appropriate assignment for a graduate level therapist.
Yeah, I
And I've
agree.
always wondered how that happens, but we did end up getting her connected to a higher level of care. That's the good news.
Right.
But yeah, but yes, I mean that's validating to know, like, no, that wasn't a good first or second case to have in grad school.
I have a guilty, I mean, I have the same thing. And then looking back on my internship program, when I was in the Air Force, I had a client that I was treating for bulimia and missed the OCD entirely. And it didn't come out until like she wound up deciding she was separating. But again, just got so sidetracked with the eating disorder, I completely missed the OCD. And I feel like what a disservice I did her because that was the more important. So, and I think just we like to have these conversations because we are imperfect and we do miss stuff. And the
Yes.
whole point of the podcast here is to
Yep.
kind of talk about, how do we do better and how do we get consultation and all those good things. But
Yeah, I just want to add really quick that we
yeah,
hear that so often when folks come to train at our clinic. Everyone will say, "Oh my gosh, I have this one client that I saw that I feel
Yes.
horrible that they replaced with me because I
right.
miss the OCD." This happens a lot with PTSD and trauma. It can often,
Hmm.
they can mask
Yep.
each other. So when you treat one, the other can emerge. And just to follow up on one of your questions, Kevin, I just wanted to say that the research shows that most therapists are afraid to do exposure therapy. So if you're
Yes.
thinking about treating OCD, or you like your OCD patients or patients with OCD and you want to do more of it, I would highly recommend, if you haven't already had specialty training, getting it and having follow-up
Yes.
supervision, because it's not as simple as just applying the model. It is really scary and hard to sit there when someone's panicking and knowing that it's your fault and not doing anything about it and riding the wave with them, even when you've done it 1,000 times. So making sure that you do have adequate support if you're going to be advertising yourself as an OCD clinician.
Right.
And it's so funny because I do a lot of like parent training and talks. And so this came up this past Friday when I was doing one at the school here in town. And I was talking to some parents and they were talking about sleep training. And one of them is like, well, should I do it or should I not? What should this look like? I need your feedback, right? And my response is pretty simple, which is like, you have to decide if you want to do sleep training, because
Right.
if I tell you I think it's a good idea, but you're not committed to it, inconsistency is way worse. Like I'd rather
Yeah.
you sleep train or not sleep train at all, but I
Right.
definitely don't want you doing like behavioral interventions one day and then giving in the next day. And I say
Intermittent
that
reinforcement is a real thing.
Yeah.
right, and not good, and very confusing to a toddler who doesn't know what's happening, right? But I tell people this, and I say this, and I really am like being truthful, and I say it, although I think they think I'm a crazy person, is like crying doesn't bother me. Like literally when my kids cry, sleep training doesn't bother me at all. It does not activate me. Why? Because I know what it's going to create. Like I know
Mhm.
the outcomes. So like I'm not getting activated by it. And that is like how you have to be as a ERP clinician. If you have your own stuff or your own anxiety you haven't worked out, this treatment is not for you yet, right? But also, if you aren't willing to take an active approach to anxiety, right? Well, how do we treat panic attacks? We don't teach them how to not have a panic attack. We don't
Right.
teach patients,
Right.
how to not feel anxiety. We actually provoke panic attacks, right? We do interoceptives. We do things to teach you to not be afraid. We have active approaches to anxiety when we're treating it. And the same goes for OCD. And I do think, like Dr. John Abramowitz talks a lot about this, that it's not for the faint of heart. Like you have,
Yes.
and it's a disservice. It is, if you want to do ERP, but you don't want to be triggered or see your patients triggered, like that's not going to work.
I love that you really emphasize getting good training, specialized training, which we emphasize on the podcast all the time, and also emphasize getting good consultation, which we also
Yes.
emphasize all the time on the podcast. Those two together are so important for any of these evidence-based psychotherapies. And it sounds like it's the case here, even more so the case for ERP.
Yeah, not to sound like a walking advertisement, but that's why we designed Minty as an app that people can use to do that. We wanted to create a scalable CE platform, but we didn't want to do it without the consultation, because we have
Mm.
enough of that already, right? And what we wanted to do was be able to create a training clinic that anyone can join that actually has all the pieces that we value so much.
And actually that segues into one of the things I did want to ask is you've both been, very integral in developing tools to make training, consultation, and support more accessible. What do you what's the single most exciting thing that innovation thing you've been a part of or shift you've seen or see coming ahead in the next, 5 years that might really expand that high quality evidence-based care for clients who have OCD, kind of beyond the traditional specialty centers even?
Oh, that's a loaded question. I feel it's funny because I feel like in the advocacy world, we actually saw a huge shift towards evidence-based care probably about 3 years ago for the 5 years leading up to that. And then I feel like we've seen this like interesting like conversion. We've gone a little backwards where we've started to have a lot of like influencers and different individuals who are not licensed clinicians, who are not doing evidence-based care, start to capitalize in this space. And it's really hard for consumers. They don't know who to believe, right? Someone with 100,000 followers feels more credible than someone with a license and training and background, and they get stuck. And I've seen it's become a little bit dangerous, if I'm being honest, as a clinician, to watch this kind of like, wow, you're pitching like not totally evidence-based interventions and calling them evidence-based, or you're doing like, and thinking about like the impact that can have on patients and being scared about that. And so I'm hopeful that we'll be able to shift back to like true, really science and allow science to be something that's more respected again, since I think we've seen it also be, there's been these volatile kind of perceptions of it over the past 2 to 3 years or since COVID. But my goal is that I do think there has been an increase in access or availability to training. I think people can watch more webinars, right? The internet has created opportunity. ChatGPT has created an opportunity for you to like get a little bit of good base knowledge, right? Of what is an evidence-based intervention for OCD. But I think the second piece is what I'm most excited about, both with Mentee and the future of mental health, is that I do think people are seeking and desiring more consultation than they ever have before. Yeah. And I really believe that that is where the most growth happens, is being able to truly do case consultation with leading experts in the field, right? Don't do it with just anybody, to where you can really dive into what am I missing? What's happening? What isn't? And not feel like you're expected to know it all when you graduate and finish your postdoc.
Yeah. Well, and just a quick point to add to that, I think this misperception that consultation is, I have this case and I must come, presented and get consultation. We call ours continued learning and consultation, because we think it's crazy to think you sit through a 2-day PE workshop and then you're proficient to kind of step forward. And even if you you're doing a really, really good job of being a client and consulting with us, we want you to continue to see videos or continue to ask, hard questions, or like, hey, can we go over the rationale again? Absolutely. So and it takes the pressure off too, that you have to come with, we want you to come before you have a client. We want you to come as you're figuring out who might be a good client to do this with. So that's exciting to hear you all are thinking that way too.
And it really helps to think about, how does this, particular evidence-based model apply to a specific individual? Like in workshops, all we can talk about are those perfect textbook cases, and to illustrate that model. When it comes to practical application of, how about this person sitting in front of me in my, I don't know what to do because they departed from the script, and how do we work with that?
Or I think they departed from the script, but when we talked through, they actually didn't. Right?
Yes, absolutely. Good point. And we get a chance to kind of, apply that at a much deeper level, get that model, the underlying theory in a much deeper level, and then have an understanding of the broad ways to apply that to the variations that we see coming in.
And I think one of the, I know that your theme is the 7 deadly sins for this season. That just while we're on this consultation topic, I think one sin is letting ego get in the way of good clinical care.
Yes.
Something that Liz and I have been learning and seeing that's been a bit troubling as we've talked about Mentee, is that folks can have a lot of ego where they don't need another training. They already went to this one on OCD. They don't need more consultation, which is so concerning. I mean, Liz and I are OCD experts that run high levels of care OCD centers and trained tens of people a year, yet we still consult with each other and our mentors,
Yes.
and
Yeah.
we have groups that we meet with monthly to consult. We don't think we are done consulting, so why would anybody else be?
Amen.
Totally agree with that. I think we've talked about that on this show before too, that, the idea that, man, when I was a grad student, I really hated taping sessions and letting people watch them and critique me, because what I wanted was for them to say, "Oh my gosh, somehow as a first year grad student, you're just amazing
Yeah.
and you know all the right things to say and all the right things to do." And I was looking forward to just being able to do things without people scrutinizing every little particle
Right.
of it. And of course, these days I'm like, "Oh my gosh, I need to talk to my
Yeah.
colleagues. I need to talk to, folks who know what they're talking about, the experts, and, point out to me, where could I have done something different, or is there something I'm missing?" I really wish I had known that as a grad student, that I'd be wanting this years and years later. And it's less available. You have to be more purposeful about pursuing it.
Isn't it so interesting when you like think about or see that competence/confidence curve? It's like at first people are very
Right.
confident, but their competence is actually quite low. And the more competent you become, the less confident you are, because
Yeah.
and that's why you're so good, is because you're competent enough, but like it's at a point where you're still willing to say what you don't know. And listen, ERP is something that I've been actively involved in the forefront of for over 20 years, and it has changed drastically. And it
Mm,
should continue to change. The way you do ERP now should be totally different than it was 20 years ago. The way we
right.
understand it, right? We've transitioned from a habituation model to an inhibitory learning model.
Yeah.
Lauren and others have really coined and really brought to light this idea of making sure people are doing values and justice-based ERP. And, there's been so many amazing changes that I think so many clinicians who were trained 20 years ago are like, well, my ERP has always worked, so why do I need something new? And it's like, because we can do something that's better, and we can do something that's more values-based. And so anyway, I mean, we should always be wanting to learn and grow as clinicians. That's what makes us better clinicians. And our patients see it and they feel it, by the way. They know when you
Absolutely.
are willing to say, let me learn, let me ask about that, let me seek consultation. That means a lot to them.
Can you imagine going to see an oncologist who was like, "Oh, well, these are the chemos I used in the 80s, and they
Yeah,
work then. So we're just
yeah.
going to keep them,
The results are still pretty good.
they're
Yeah, but here's this
decent."
other study with better results. But like
Yeah.
these are fine. We don't need to worry about that.
Yeah.
It's interesting that I feel like we are the only field, or one of the only fields, that does that. Should we now that you said the sin word, let's go there, because that is the theme for this season, are the seven sins of EVP work. So we've already talked about this sin of don't let your ego get in the way of consultation. What else have you seen in this arena? Common misconceptions, or things that you see people overlooking, or kind of not doing well with ERP. I know you've trained and consulted with lots of folks, so
Yeah, I mean, for sure. I think before that, I was just going to also say, I think the concept that you can do a training in 2 or 3 days, like we talked about earlier, and know what you're doing is a
Yeah.
huge misconception.
Yes.
This takes years of and dozens, if not hundreds, of patients and work and specialty training and supervision for you to really know what you're doing. So be thoughtful of that. But our old school ERP model was really this big fear factor model, right? It was that concept that, oh, you're afraid of contamination. Let me just expose you to as many gross, disgusting things as we can. And the more you get triggered, the better, right? The more you get activated and learn to not respond, the better. And it really didn't hit home with a lot of patients for many reasons. Number one, a lot of patients were like, I'm not willing to do those things. Like those don't make
Right.
sense. They don't align with my values. I'm not really interested of it.
hmm
And not really interested in it. And then the second piece is that I also think the problem with this fear factor approach is a lot of patients weren't really willing to do things that didn't make sense because it didn't really align with them. And what I mean by that is that one of the biggest pitfalls I get is I will have consultations or people that will call me all the time and say, hey, I've got a patient with da da da, what exposure should I do? My answer is the same. It's like, I don't know. You should ask your patient. And
Yeah.
they're like, well, what do you mean? And I'm like, you can't guess what exposures to do. I can't guess. Your patient needs to tell you. And how do you ask your patient? You simply say to them, what are you avoiding? What are the
Yep.
things, if you didn't have anxiety and OCD running your life, you'd be doing? and let your patients tell you, because those sort of things they tell you are going to be the exact things that they're willing and motivated to do, because it's things they want to get back to. It's things they're missing. So ERP is not about how triggered can we get you and can we teach you to overcome it. ERP is about, can I teach you to face your fears, face your anxiety, that if you don't face, it will hold you back from living the life you want to live.
Right.
And when you start doing that and you start facing your fears and you start becoming empowered and understanding how, like, A, that you can do this, but B, how good it feels when you do something you didn't think you can do, you will get momentum.
Love it.
Yeah, I can give an example of that with my sin that I was going to share, which is identity related themes for OCD. So we have a long history of calling sexual orientation related themes homosexual OCD. There's a lot of folks with OCD that are afraid of saying a racial slur. And in these cases, when there's an identity related theme, I was trained, and most people slash maybe everyone was trained to up to a certain point date, that we should just have clients do what they're afraid of, right? So it'd be a more basic version of what Liz just said. And so I'm afraid of saying a racial slur, so they would have people say racial slurs. I'm afraid of being that I'm gay, and so they would have people sit next to gay people and risk catching it, or write a script about how horrible it would be if they were gay. That might be what the patient says they're afraid of, but you're not actually asking them what they're avoiding, what is in line with their values that they're not able to do. So by being more thoughtful, the field has shifted towards, we might call it identity related OCD or ERP or justice based. We want to really get at the core fear. So the core fear of, I'm afraid I'm going to blurt out a racial slur, is that I'm a bad person and it's going to come out if I lose control. Right. So, and what are you avoiding? I'm avoiding talking to people because I'm scared that a slur is going to come out. I'm especially avoiding talking to people of color. Okay. So let's think about what the goal is. The goal of ERP isn't to get more comfortable with saying racial slurs. The goal is to help them get back into the life they want to live. Right. So, how can we help you practice having conversations? Maybe we start with just the weather, and then we shift towards more political topics as we move up the hierarchy. As it relates to sexual orientation, how do we involve ourselves with watching media created by gay artists and enjoy it while also feeling anxious, versus acting like it would be dangerous or contagious to be gay? So that's been a huge shift in the field. So I'd say the sin would be taking a client's OCD at face value and not really understanding the client and the context around it and what the goal of treatment is.
So important.
Yeah.
And like we said, and we're not trying to equate them, but, it has a lot of resonance in the work we're doing with prolonged exposure therapy for PTSD. It's so important to understand that core fear and what it is that they're actually avoiding. What ground have they lost in their life that they want back to make these effective?
And you have to be thoughtful about the identities in the room, right? Like the exposures you're going to assign people have to consider what's safe for a client of color to do versus a white client. What's safe for a queer client to do? Where is it safe to do that?
100%. And a small fun fact is that, one of the main founders of ERP was Edna, who also, of course, is, all the PE work. So, so there are so many similarities and so much overlap. I think the big difference is OCD has a little bit more of an uncertainty flair, right? Where we're going to target more uncertainty than we do with trauma. And then, of course, that response prevention, right? We can do exposures all day long with people with OCD, but if they're not doing ritual prevention, they're not going to get better.
Yeah. This is so fantastic, and I really, really appreciate you coming on to tell us about OCD and kind of the latest advances. We like to try to end every episode with, like, we call it actionable intel. So some thoughts about some tips for people who are listening today that they can take with them and apply right now to improve their work, the therapy that they do.
Incoming actionable intel.
And you've already mentioned a few, like, one is, if you're working with OCD, you should get some good expert training and consultation. I'll throw that out there. Yes. But what other tips do you have for our listeners, who are listening right now, who want to apply things? You've mentioned Menti a few times. I hope you mentioned that and tell us a little bit more about what Menti is.
Yeah, so Menti, which you can find at menti.com or download us on the App Store, it is a really amazing training app that kind of does everything. So there's going to be evidence-based training from leading experts, OCD and related fields, and you can do individual and or group consultation with leading experts. So experts like John Abramowitz, Dr. Storch for OCD, David Tolan for CBT, Edna Foa does consultation on Menti for exposure work. So you can hear and learn from leading experts who you otherwise might not have access to. And that was really the goal. Lauren talked about this earlier, but both of us were lucky enough to have training at amazing medical centers and academic institutions that a lot of people don't get access to. And one of the things we realized is so many people don't have access to the training that we did, and how can we help create that? So that was the goal. So that's my number one thing, is get training and get in a consultation group. Make sure it's a consultation group with leading experts who you really trust. And sometimes you'd be shocked. So our program, for example, is one of the few res programs. We take people all the time who will come and do like a 2-week training observation because they just want to come and learn. Because so many people, especially I feel like 5 or 10 years into their career, they're like, well, I can't go redo my postdoc, or I can't, like, how do I go get that training? And so sometimes I just want to say, like, don't be afraid to ask. And you will find that most of us in this field are actually like, we want people to learn. We want people to get better trained, and we're on that mission with you.
Kevin, there are people. We feel the same way. We're always like, we just want to be there. We just want you to succeed and feel supported and be able to do this therapy with confidence. So
You're our
that's great.
people. Yeah.
You're our people.
Lauren, you were going to say
Yeah,
something.
I was just going to add, if folks are really now feeling nervous about identity-related themes in OCD, they can Google justice-based ERP. There are podcasts about it. There are webinars about it, and there are 2 articles about it that we've written up about how to apply this. The second article that expands it across all identities has a full table that lists every sociocultural identity that folks have and how to create exposures that are justice-based. So that's a good tool to use.
Fantastic. And we'll include a lot of these resources in the show notes. So we're not going to ask you to try to repeat the URLs and the links and stuff, but we'd love for you to provide those. We can include those for the show notes for the listeners to look up if you're interested in any of the resources that have been mentioned so far. But thank you so much.
Yeah.
This has been very enlightening, very fascinating. And like we said, I mean, resonates in many ways because of our backgrounds too. But yeah, thank you so much.
Yeah, thank you for having us. This has been a really energizing conversation.
Yes, thank you. And thanks for your dedication. I just think it's so nice and rare at the same time, when you hear so many people on the same mission and goal, which is just to help patients get good treatment sooner, and I think at the end of the day, that's our goal. And we're excited to be on that journey with you guys.
Well, Liz and Lauren, we hope this is just the beginning of a beautiful friendship, and we will stay in touch and follow your path, and hope you can join us for some stuff too. But for all of you who tuned in, thank you so much for listening. As always, we love to hear from you. If you've got a sin you want to share, feel free. We also welcome ideas for guests and future podcast topics. So check out the link in the show notes for the speak pipe. I never repeat that with Kevin
It'll be in the
on
show
the
notes.
podcast. So yes, it'll be in the show notes, and we hope you tune in again soon. Thanks so much for coming again, Liz and Lauren.
Thank you.
Thanks.
And
until next time, stay curious
and mind your EBPs.
Bye, everybody.
Bye.
Remember, we love hearing from our listeners, so leave us a message on SpeakPipe or send us an email. Both can be found in our show notes. Our theme music is Failed Attempts by Nitro, and our administrative assistant is Bree Mercer.
Thanks for listening to Practical for Your Practice.
If you like what you're hearing, please feel free to follow us, rate this episode, and share it with others.
Until next time,